And now I'm unmuted. Hello. I'm Dr. Tracey Steady Hardcastle, and tonight we're here to talk about thyroid function. Last night we did a big overview of all of the different factors that can contribute to weight gain in midlife, specifically for women. More than just sex hormones, but also a deep dive into sex hormones. Whereas tonight, we are very fortunate to have someone who is a thyroid expert here to answer all of your questions and to give you a wonderful education around thyroid and testing and how important it is to do more than just the standard testing. We can't really separate out just thyroid function from many other things, and you can't treat labs. You have to treat the whole person. And with me this evening to talk about that is Dr. Amie Hornaman. Dr. Horniman has devoted her career to helping women reclaim their health by addressing the root causes of thyroid and hormone dysfunction through the power of functional medicine. Known as the Thyroid Fixer, which is a good title, Dr. Amie is a practicing hormone optimization specialist and an internationally recognized leader, speaker, educator, and advocate in the field of thyroid health. She is the CEO and founder of the Advanced Thyroid and Hormone Clinic, an international telehealth practice serving patients across the US and Canada, and creator of the science-backed Fixer supplement line designed to treat stubborn weight, fatigue, low libido, and hormone imbalances. Dr. Amie is the host of the top-rated podcast, The Thyroid Fixer, empowering listeners with the truth about thyroid health, hormones, and functional medicine. She has been featured in documentaries including Shield on Amazon Prime, Ageless, and Hormones, Health, and Harmony. Driven by her own experience with thyroid and hormone misdiagnoses, being told by 6 different doctors their labs were normal while gaining over 20 pounds, battling crushing fatigue and losing her hair, Dr. Amie understands the frustration women over 40 face when their symptoms are dismissed as just aging. Welcome, Dr. Horniman. It's so lovely to see you.
Hi, Dr. Steady. Thank you so much for having me on. I'm excited for tonight.
Me too. And I'm excited for your book to come out. It's you can see it behind her. It's very exciting. And we do have a link that'll be put in the chat for you to pre-order her book. And I probably was planning on waiting for that, but I got so excited looking in the background that I had to mention it right away, and we'll mention it several more times, I'm sure. Um, so, so Dr. Amie, you saw 6 doctors that told you you were quote unquote normal before the 7th finally diagnosed hypothyroidism. And then you were put on Synthroid, and that didn't seem to help. So it sounds like that really shaped your ideas about normal labs. Can you take us back to that experience and how that felt for you and how that shaped the future where you are today?
Absolutely. I think a lot of us in this health arena came from a pain to purpose story. Like we all went through something that opened our eyes. Even doctors that move from conventional medicine to functional medicine, they normally go through something that really just shifted their perspective, like you said. So for me, it was literally watching my body rebel against me when I was doing all the right things. So I was in contest prep mode for a bodybuilding show. I did the figure end of things where you still remained feminine, but the bottom line is you are stepping on a stage at your leanest, your lowest body fat percent possible while maintaining your muscle. I had done this plenty of times. And this one show I was getting ready for, the scale kept going up. And I don't mean like, oh, it went up 2 pounds. No, it went up 25 pounds before I stopped getting on the thing anymore because I didn't want to become any more depressed than I already was. So I literally watched my body shift and go haywire and rebel against me. I had no control over what was happening in my body. I had control over what I was doing. I had control over what I was eating, how much I exercised, and that was on point. Chicken, broccoli, fish, asparagus, going to the gym twice a day, doing cardio and weight training twice a day. And the scale kept going up. Now, all in all, I truly believe that it went up about 40 pounds over the course of about 6 months. That was my entire journey from misdiagnosis to misdiagnosis to misdiagnosis to finally getting diagnosed. All 6 doctors misdiagnosed, 7th one diagnosed me. And I'll get to that in a moment. But during those 6 months, I mean, I was depressed. I was very depressed. Yes, the thyroid probably played a role in the depression, but when you see your body just expand, and you have no control whatsoever over what is happening. That sends you down a deep spiral. So many nights of crying in my car. I would hide my body under sweatshirts. I would avoid going out. I was in my 20s. I would avoid going out with friends. I didn't want to be intimate. I didn't want anything to do with anybody because I didn't want them to see me and see the state that I was in. So every single doctor I went to back then said, "You're normal. Everything is fine. It's all in your head. Eat less and exercise more." I heard every medical gaslighting term there is under the sun in my 20s. Finally, the seventh doctor actually touched my throat and said, "Swallow." And she said, "I'm feeling a little nodule here on your thyroid and your tests," which to this day, I don't know exactly what tests they ran, but I think we can all guess. And I'll get to that in a minute. "Your tests show that you have subclinical hypothyroidism. It looks like you have a little bit of Hashimoto's here. We'll do an ultrasound to double check it, but here's a pill." So I left her office thrilled. Like, I have a name for what's going on with my body. And now I have a pill that's going to fix me, right? It's going to fix me. And I gave it 5 months. There was no change. No change on the scale. No change in my energy level. My hair was still breaking and falling out. So I went to the best doctor of all, Dr. Google, and I started doing some research on my gateway computer back in the day with my dial-up internet. And it said to me that this little pill that I was taking called levothyroxine was T4. And that's an inactive thyroid hormone. And it turns out there's all these other thyroid hormones. There's T2, there's T3, and T3 is a pharmaceutical. And oftentimes doctors will pair up T3 with T4 because T3 is the active thyroid hormone. It's what T4 has to convert and become. And I'm like, well, this is fascinating. So there are other options out there. Okay. So I went back to my endocrinologist who diagnosed me. And I said, "Hey doc, there's this other pill, T3 and T4 and T3 work really well together." She goes, "I don't do that. That's not standard of care. Standard of care." And I said, "Well, thank you. I'm going to find someone who does." And that's what led me into the world of functional medicine. Even way back then, I don't even think it was called functional. I think it was still integrative alternative. It was under that umbrella. But it led me into that world. And I found a practitioner who spent 83 more minutes with me than any other doctor had. I was used to getting the 5 to 7 minute visit and then booted out the door. He spent 90 minutes with me, going through all of my labs, testing everything, and actually personalizing a treatment that worked. And yes, it included T3. So we'll get to that tonight, I know. But that was the turning point for me. And I was in a major medical system. I wasn't in a little small town. I was in a major medical system considered to be the best of the best, right up there with Cleveland Clinic and Mayo Clinic. And I still was misdiagnosed. I was still mistreated. I was in my 20s. So I even had the thought back then, I'm like, if this is happening to me, I'm young, vibrant, youthful, I'm in a major medical system, how many people, how many women specifically are getting the same treatment or mistreatment? And that's what led me to totally change careers. And that's why I'm here doing what I do today.
I'm just going to ask our audience really quickly to put a 1 in the chat if you've ever felt gaslit or dismissed by a physician in their office, and put a 2 if that's never happened to you.
Yeah.
I have not
Oh,
seen
yeah.
a 2 yet.
I've not seen it too yet.
I was
No.
hoping, it would be nice, but oh, we saw
Oh,
one
there's
2.
one.
One
Yeah.
2. Two twos. But the fact that I can count the number of twos on one hand kind of says it all, right?
Right.
Um, yeah, so all right, now 3. But this probably really informs how you help people, right? In the way the methodology that you use to help people, not just in terms of what kind of testing you're doing, but in terms of, I don't know, listening. Can you would you like to say something about that before I move on to the kinds of testing that you like to do?
Yes, because it's a great tip for anyone out there listening. If you do not hear the following 4 words from any practitioner, doctor, NTPA, DO, I don't care. Any practitioner you're working with has to ask you these 4 words, or you fire them and you leave and you walk out and you find somebody else. Right? Okay, write these down. How do you feel? Because if they're not asking you how you feel, then you are nothing more than a lab value. You're an algorithm. You're a dollar sign. And that is it. And they don't really care about you as a human being and how your quality of life actually is. So you have to hear those four words or you're done. You leave.
Yeah.
Yeah.
Yeah, for sure. So let's talk a little bit about the labs that you recommend and the differences between what's considered normal range and optimal range, like how those are derived and what that means for you and how you practice.
Absolutely. So when we're looking at lab tests, we have that standard lab value range that's off to the side. So you have the test, you have your result, and then you have that standard lab value range. And that's really where most practitioners that's what they rely on, but it's there's major issues with that because those standard lab value ranges were taken from people in the hospital, from groups of sick people. They weren't taken from the healthy, the vibrant, the 70-year-old skiing down the side of a mountain, the 65-year-old that's throwing weights around in the gym and looks like an Adonis. That's who we want to test because that's where functional medicine comes in and says, give me your best. And we know that that's going to be a more narrow range. It's going to be a smaller window that a person has to aim for and fall into. But that's where we know they're going to be healthy, vibrant, and they're going to be living their best life. So when we look at thyroid labs, we can't go by that standard lab value range on the side. We have to go by the functional medicine optimal range. Now, even within that, I can give you the numbers all day long, but you are still a human being. You're more than a lab value. So we always overlay your symptoms with these labs. But what I'm going to tell you in the optimal ranges are in general where we want you to fall, where we know that you will feel your best. So TSH, we want that less than 2. Now that standard lab value range will go all the way up to 4.5. It's been debated for decades. It started at a 10 and then they lowered it to a 6 or a 6.5. Now it's down to a 4.5. Functional medicine, we say we want it below a 2. Now with TSH, I want you to understand this is one of the only lab values that we see where high means low. So the higher that TSH goes, the lower and slower your thyroid is functioning. So it's this weird kind of inverse relationship with the ranges for TSH. Next up is free T4. That's your inactive thyroid hormone. I was given that pill. That was T4. T4 has to convert and become T3. With T4, and this is going to tie into another lab marker that we're going to talk about, reverse T3. T4 has two paths it can go down. It can convert to T3, the active thyroid hormone, or it can convert to reverse T3, the inactive thyroid hormone, the one that basically puts your body in hibernation mode. So it can go down either of those paths. So therefore, if I see a free T4 elevated, by elevated, I mean really above a 1.2, a 1.3, alarm bells start going off in my head because I start thinking, okay, this person is on too much T4 thyroid medication. And that can be in the form of natural desiccated thyroid, or that could be Synthroid or Levo. And I bet their reverse T3 is going to be high. I literally just saw this today in my Facebook group. Someone posted their labs. They said, okay, my free T4 is a 1.8. And in my head, I went, okay, I'm going to bet that her reverse T3 is a 26. And sure enough, her reverse T3 followed 37. So whenever we have too high of a free T4 level, that can actually be a problem. I like it 0.8 to 1.2. Free T3, the active thyroid hormone. Now, free T3 and reverse T3 are going to be your two most important tests in my eyes. Without those two tests, we know nothing about your thyroid, nothing. So free T3, upper quadrant of the range. So that's beautiful because I don't care what country you're in. You take that standard lab value range, you cut it into 4, and I want you in that upper quadrant of the range or even slightly over. Even slightly over is fine if you're saying that you're feeling amazing and you're not hyper or jittery. Reverse T3, the anti-thyroid hormone, the one that shuts your body down, puts you in survival hibernation mode. We want that less than 12. The range goes to 24. But anything above a 12 tells me that you're not converting your T4 to T3 properly, and that can be due to a genetic SNP that I know we're going to talk about tonight. Reverse T3 less than 12. And then there's the TPO, thyroid peroxidase, and TG, thyroglobulin antibodies. We want those both at 0. Now, your standard lab value range, some labs have it less than 9, some have it less than 34. Here's my argument with that. Any antibody that we have in our body, any marker for Hashimoto's is a soldier that's going out and attacking your thyroid. So if we have the lab range cut off, let's say less than 34, but we have a TPO of a 20, we have 20 soldiers that are going out and beating up our thyroid gland and destroying it. So why would we wait until you have 35 soldiers? Why wouldn't we address the 20 right now and do something about it to possibly push it into remission or address the issue that's displaying on the labs? So those are the markers. We always have to go by optimal and not just normal.
Perfect. I love that. Um, let's take a quick look at our poll, just so that we can see what our audience is thinking about. Apparently, there was a little bit of confusion about one of the questions, which I apologize for. So, in the last few months, how often have people noticed possible thyroid-related symptoms? And very often, we've got 36%, and sometimes with 37. So, I guess there's really um, no question why people are here, right? They're wondering, does this apply to me, right?
Absolutely.
Um, let's see. Have you ever had your thyroid checked with blood tests? And yes, a full thyroid panel, more than just TSH, 70%. Wow,
Good.
amazing.
Mm-hmm.
That's really great. How familiar are you with the idea that your genes can affect your thyroid hormones? 43% somewhat familiar, and then 21% very familiar. And then we've got some more on the heard of it and not familiar at all. How comfortable do you feel asking your doctor for more than just a TSH test to check your thyroid health? And I think this was the one that people had some confusion about, because I was asking about comfort level in having the very discussion that I think you are going to help us to understand how to have with
Mm-hmm.
their doctor. And oh, rarely. Oh, that's interesting. I think what was confusing to them was the um was the options of daily, weekly, 2 to 3 times a
Right.
month, and rarely. Those must have gotten moved from a different question. So my apologies on that. What is your main goal related to thyroid and hormonal health right now? And we've got a tie pretty much between having more energy and managing weight. So
Mm-hmm.
all of that makes sense. And some people are here just to learn, which is totally awesome. And we're glad that all of you are here, for whatever reason brings you here. So let's talk about, you mentioned reverse T3. Um, and let's go into a little bit more detail about that, because that might be one of them that people have not heard about that much, but that you really talk about a lot. And some of our gene reports really inform people's tendency toward factors that can increase reverse T3. So let's
Mm-hmm.
talk about some of the factors that can increase reverse T3. And then I'll at some point talk a little bit about where people can look in their DNA 360 reports for factors that can contribute to that. Because if you know the factors, your genetic factors that are contributing, and can take action on those, as well as getting testing and supplementing with medication if necessary, or supplements if necessary, you can also work at it from the other end, which is trying to prevent some of the things that are contributing to it. So, Dr. Horniman, please let us know, what are some of these factors?
Okay. So that T4 to T3 conversion process, I always say, is like running 10 Tough Mudders in a row for your body. It's really hard for your body to do. And there are so many things that can get in the way, and more factors now than, let's say, 20, 30, 40 years ago, because we're living in a toxic soup world. So we know that toxins, environmental chemicals, stress. So that can be from a toxic burden, or it can be from stress, like actual situational stress that you're going through that then affects your cortisol. So cortisol, high cortisol or low cortisol will affect reverse T3, mostly high cortisol. We know high cortisol pushes up blood glucose, insulin resistance. That will also push up reverse T3. So high cortisol, insulin resistance, high glucose, estrogen dominance, iodine deficiency, magnesium deficiency, selenium deficiency, vitamin D deficiency, B deficiency, and then, of course, the genes, the D101, D102, genetic SNPs, that can influence T4 to T3 conversion. I think I'm hitting everything. I'm sure there's some other factors in there that is slipping my mind. But the bottom line is there are so many factors that can impact that conversion process. That's why we say you have to get reverse T3 tested. every single time. And really, sometimes it's as simple. And I also see this in patients being treated with thyroid hormone, but they're treated with the standard of care. Here's some T4, Sally. Oh, you're not feeling better? Let's take that from a 75 to an 88. Let's take it to a 112. Let's take it to a 125. Now, we also see this in the functional world because there are functional practitioners who may or may not really know the thyroid and the nuance aspects of it. They try, but they don't have it nailed. So, what I'll see there is functional practitioners going, oh, yes, I'll prescribe natural desiccated thyroid. Here you go. Have all that you want. And they're not realizing that that NDT, while it is better than synthetic T4 most of the time, it is better because it contains a little bit of T3. It still is 80% T4. So if someone has a conversion problem, natural desiccated thyroid will make them worse because it's 80% T4. And just remember, the only thing that converts to reverse T3 is T4. So if we have too much T4 coming into the system and we have those issues that impair conversion, all of that T4 is just going to continuously push up reverse T3 and basically put your body in survival mode.
Yeah, so what would be the symptoms? So let's say that that exact scenario, and I know I'm going off book, which I always do with you for some
Oh,
reason.
yeah, no, let's do it.
I just get really curious. So if someone, let's say they are on desiccated hormone thyroid, and they're still so that's still 80% of that is T4. What are some symptoms as this reverse T3 ramps up and up and up? What would someone be looking for
You're going to
symptom wise?
all the hypothyroid symptoms coming back. So it's the weight gain, the inability to lose weight, fatigue, hair loss, brain fog, constipation, anxiety, depression, memory issues, loss of the outer corners of your eyebrows, cold intolerance. I mean, you name it, just all the hypo symptoms come back. And a lot of times we'll see this in individuals. They might start, let's take NDT for an example. They'll start on natural desiccated thyroid and shifting from T4 only to NDT in the beginning, they're like, whew, this is nice. I finally feel a little something, something. I feel a little bit better here. And then they go, oh, but then I got worse again and all the symptoms came back. What the heck? Well, it's because that initial shift over to giving your body a little bit of that T3 was like a party in your body. Like your body went, woo, this is awesome. But then over time, all of that T4, the 80% T4 took over and kept pushing up your reverse T3, which is reverse T3. I want you to think of it like a bouncer at the club. So your cell has a receptor site on it for T3. Every cell in your body has a receptor site on it for T3. Reverse T3 is like the blockade, the bouncer outside of T3's door. Arms crossed, looking at that beautiful T3 in your system saying, yeah, you're not coming in tonight. You're not getting in. So the T3 hormone can't actually get to its receptor site on the cell to do its job, to give you metabolism, to light up your brain, to give you energy, to grow your hair. So with too much T3 in the system, it's blocking that T3 from getting to the receptor site. So it doesn't matter that you have 20% T3 in your natural desiccated thyroid. You got 80% T4 that's pushing up your reverse T3 and blocking T3's action anyways. Now, sometimes what we'll see, and this is a little bit more advanced, but what we'll see in labs sometimes is when that reverse T3 goes up, and I talk about this in the book too, and I have it broken down with reverse T3, 12 to 16, 16 to 24, 24 and above. Sometimes what we'll see when reverse T3 really goes high, we'll actually get a really beautiful free T3 number. Like we'll look at the free T3 and we'll go, well, that's in the upper quadrant of the range. That's where optimal is. That's where it's supposed to be. But yet it's not because it's almost like a dam. You know, when you have the dam blocking the water from coming through, that's what reverse T3 is. So you get this backup in the system, in the bloodstream of T3, especially if someone is taking NDT or taking liothyronine. It will look pretty in the blood because when we draw your blood, we're picking up on the T3 in your bloodstream, but it's not actually getting to the cell to do its job. So a person with an elevated reverse T3, even with an optimal free T3, will feel horrible. They will literally feel like their body is in hibernation mode.
Yeah, which is really, really unpleasant. And um, which is why without that one test, you might not have a complete picture. And I know that you said that, and I know that we said it before, but there are going to be some points that I'm going to reiterate just because I think they're so important.
They're so important. Yep.
And so when you're looking, those of you with your DNA 360s out, um, when you're looking through your reports, mood and behavior, which is going to talk about your stress hormones. It's going to talk about your production. It's going to talk about your clearance and how much and for how long these things are going to affect you. So that's a great report to look at in conjunction with this. Also, your inflammation report. So how well your body detoxifies. Whether, and we're going to talk a little bit more about these later, but if you have factors that contribute to an overall baseline of inflammation that might be a little bit higher, or if you don't, but sometimes it might spike a little bit higher than others in the presence of illness, and then how long before that comes back down after that. Um, the cortisol piece is in the mood and behavior, in the stress one as well. Then if you're looking in your diet and nutrition, you can look for your vitamin D status, and you can look for your metabolic health. So are you more likely to end up with metabolic dysfunction? And how important could that be to this very picture, so that when you're working on your thyroid health, managing the rest of your health is really important, as well as hormonal health, which is what we're going to get into a little bit later. But Dr. Horniman, how important is it to work on all of these other factors while you're doing this work? It's not just a matter of figuring out the problem and while the medications and supplements are amazing and can really help people, especially because when you're tired, it's hard to manage these other aspects of health, right? So there's a little bit of this feeling of being on the hamster wheel of not feeling well. But I think it's also important to work on these things. Correct me if I'm wrong on that.
Oh, no, you're 100% right. Because you can't do anything in isolation. Just like we can't just look at the thyroid and ignore hormones and insulin and cortisol. We can't just treat your adrenals and ignore the thyroid and hormones and insulin and blood sugar. We have to look at everything as a whole, as a full picture, because it all plays together. So if you're not addressing your stress, your lifestyle, what you're putting in your mouth, your sleep, your nutrient status, then you can take all the thyroid hormone you want, but it's like putting thyroid hormone on a dumpster fire. Like it doesn't go. It's not going to work. And then the flip side is, okay, yeah, you can sleep and control your stress and do your nutrients, but if your thyroid's in the toilet and you're not addressing that properly, then that's not going to work. So it all works together. You have to build the foundation for any kind of hormone replacement, whether it's thyroid hormone replacement or bioidentical hormone replacement or supplements for that matter. You have to have the foundation for anything else that you put into your body to actually work the way that it should.
Totally.
Yeah.
So let's talk a little bit about thyroid and sex hormones, because this in perimenopause and menopause, these things directly can affect the thyroid. And we touched on this last night, so we don't have to spend a lot of time here. But some of this can even change maybe which type of or which uh, mechanism which form you choose to do it, like whether oral or topical for estrogen.
Mm.
And if you can just briefly outline how the sex hormones changing in perimenopause changes how thyroid hormone works, the effects on the thyroid, and how it works in the tissues.
Absolutely. So first we'll start with a concept that I talk about in the book called thyropause. And the definition of thyropause is when your thyroid gland basically craps the bed after the age of 40 due to those fluctuating hormones. Now, what do I mean by that? Let's back up a moment and look at Hashimoto's. And then we'll tie all this into hormones. So when we're looking at Hashimoto's, we know that about 90 to 95% of all hypothyroid cases, hypo, low and slow thyroid function is Hashimoto's thyroiditis. So it's connected to an autoimmune condition. What do we know about autoimmunity? We know, and I love referencing the three-legged stool analogy. I give credit to Alessio Fasano. He's brilliant. uses this analogy of a three-legged stool. The one leg, you have the genetic predisposition. The other leg, you have leaky gut, which pretty much we all have at this point. And then that third leg is a trigger, a stressor. Now, one of the three pivotal times in a woman's life where we can see Hashimoto's express itself, basically that switches in the off position and it just gets flipped on: puberty, perimenopause, menopause, and pregnancy. So puberty, pregnancy, perimenopause, menopause. Hormonal fluctuations. That's what all of those share. Hormonal roller coaster fluctuations. So when we specifically look at perimenopause, menopause, what happens? Well, first of all, our progesterone drops first. And that can drop in a woman's 20s. And right there with that progesterone drop, it's affecting the thyroid because it's affecting T4 to T3 conversion. It's affecting our cortisol level. We just said that elevated cortisol will push up reverse T3. And it's just a time where the body, it goes, whoa, what's happening? There's this wild ride of hormones happening. And that is a stressor. So ladies, even though pregnancy is a beautiful thing, I think you would all agree it is a huge stressful time on your body, right? You're gaining weight, your body is changing, you got hormones all over the place. Well, that's why it's so common for a woman after her pregnancy to go, well, my body went to hell in a handbasket and I never got it back. And some doctor told me I had postpartum thyroiditis. Well, all that means is that you have Hashimoto's and that switch turned on. Same thing happens in perimenopause, menopause. So progesterone drops first, followed by testosterone. Testosterone is our armor. That's why women get hit more than men with Hashimoto's. It's because testosterone is this beautiful armor shield that protects you against autoimmunity. That's why women have more autoimmune conditions than men do. So testosterone drops off next, followed by estrogen and estradiol. And that's when we start, we'll start the hormone replacement all the way along. My preference is as soon as your hormones drop, let's add the hormones in. Let's not wait till 5 years after menopause when you're, dried up and miserable. Let's add those hormones in early. But we do have to look at the thyroid in conjunction with that, with the hormonal changes all the time, because thyropause is real. And while I absolutely love the fact that we are getting more and more of a spotlight on women's health and on menopause in general, we have 5,000 perimenopause books out, 10,000 menopause books out, and there's more to come. But what about the master gland that controls the entire show? The thyroid. Like, we should be focusing on thyropause even before we focus on perimenopause and menopause, because thyropause could be prevented. Perimenopause and menopause, unless you figured out how to age in reverse like Benjamin Button, you're going to go through perimenopause and menopause as a woman. But you don't have to go through thyropause if we just get a little bit more attention on the thyroid. So with these shifting hormones, we always have to look at them in context of the thyroid. Now, you had mentioned, and if you want me to dive into it now, let me know, but the actual delivery forms of hormones. The one form that we do not do, well, we don't do pellets because we do telehealth. And what I see with pellets is another roller coaster ride, especially with testosterone pellets. A woman will shoot up high and drop down low. And that's the last thing we want us are going on a roller coaster. We want nice, steady flow of hormones, steady state. Let's keep them level all month long and not send you up and down. But oral estrogen is notorious for raising sex hormone binding globulin and thyroid binding globulin, TBG. And this will bind to, yes, your sex hormones. SHBG will bind to sex hormones. TBG will bind to thyroid hormones. So as you're maybe in the process of trying to get optimized with your thyroid and you're taking an oral estrogen, that can increase your TBG. And then you'll be saying, well, wait a minute, I keep going up and up and up in my dose of thyroid hormone. Nothing's happening. Well, that's because TBG is coming in and literally binding to the free T3 and the free T4 that your body is making, and specifically the free T3 that's trying to get to the cell to do its job.
So I have a question for you. I know that you
Yes.
can test for SHBG. Can you test for TBG as well? Is that something, does that test exist? I feel like I'm always asking you these random questions.
No. It's a great question. Yeah, you can. We honestly don't even look at it that much because we will only use transdermal and like a cream or a patch when it comes to estradiol. So we'll use estradiol, bias, cream, or patch form. Very rarely do we use an injectable form of estradiol. Occasionally you'll get the random patient that just does not respond to any other form, even when we increase the dose. But we just stay away from the oral, and we usually don't have to worry about that because we know, listen, it's hard enough getting a woman's estradiol level up, that FSH down, getting her into that beautiful optimal range. The chances of her going too high and actually being a true estrogen dominant. I'm not talking about estrogen dominance through progesterone deficiency. I mean true estrogen dominance where she has too much estrogen in her system. I very rarely see that as an issue. And I know myself and Tracy Wood were both on rhythmic dosing, like a Wiley protocol. So personally, I'll talk about me. I take very high doses of estradiol, and I love it, and my body thrives on it. If anybody would have an elevated TBG binding to their free T3, I would. And I don't see that an issue because my delivery route is transdermal. So I really don't have a problem with elevated TBG binding to my thyroid, even though I'm on way higher doses than most women are of estradiol.
I just figured I would ask because I know
Yeah,
that there are some people in our community who are on the oral, so I just wondered, is that something they can test for? Okay. So let's shift out of the sex hormone conversation because I want to get back to the DIO2 gene and thyroid hormone conversion because this is one of the genes that is in our reports. And so some people who have certain polymorphisms here might struggle with this conversion of T4 to T3. Even and especially if they're not getting the full thyroid panel, they might not know. So let's talk a little bit about this gene and then how you might change your treatment.
mhm,
Um, of course, we would look at more than just genes because we are not just our genes. We're also everything that our entire lifestyle. So you would always do labs, but if you saw that someone had one of these polymorphisms, what would you start to think about treating this person differently than someone who didn't?
absolutely. So I actually have and you'll have to help me with this. Is it if I have one SNP on each? What is that one?
Uh,
Homozygous?
Heterozygous.
Heterozygous. Okay. So I have one SNP on D101 and D102. I don't convert at all. Like you cannot give me a drop of T4 or I will go hypo. I will immediately convert it to reverse T3 and I will go deep hypothyroid. I know because I've experimented on myself and I've tried it. So what this means is that you're going to have a tougher time converting that T4 to T3. Now, what I have found in my patient population that has done the DNA test and really you're basically the only company that tests for it, by the way. I used to only be able to find it over in Europe. So someone would have to order a DNA test from Europe, but you guys do. So I love this. Um, when I look at our patients, it's really interesting because someone might have the heterozygous marker and they're fine. They convert T4 to T3 just fine. The reverse T3 is less than 12. We have them on, let's say hypothetically, 50 micrograms of Synthroid and 20 micrograms of liothyronine twice a day. And they're loving life. But then you have someone else, like myself, that you give that 25 micrograms of T4, you give 12.5 micrograms of T4, and I'm 10 pounds heavier and clinically depressed in a week. So it's very interesting to see, and I know you talk about this all the time, is that your genes load the gun, environment pulls the trigger. You have the genetic predisposition to not convert well, but do you or don't you? So I love this test because it at least gives us an insight. I would never put someone with a genetic SNP there on the D101 and D102, never put them on T4 only. I mean, I wouldn't put people on T4 only in general because it works in the stat is about 2% of the population. I argue 0%, but I'm sure there's a random person out there on just Synthroid that's loving life. Okay, I want to meet them, put them on my wall. They're a unicorn. But most of the time, we're going to see issues in converting. But if we have that data from a genetic report, we can so much better tailor their treatment. And now we're still going to get feedback from that person, and we're still going to test their reverse T3, and we're still going to see, hey, maybe this person requires T3 only, or maybe we need to just change the ratio. Maybe we need to bring them to like an 80% T3 ratio with 20% T4. Because here's how I look at things too. And it's worth saying in the context of this topic. T4 is like your savings account. T3 is your checking. Everybody wants to have some money in their savings to pull from on a rainy day. So we pull from savings, put in the checking, use it. People like myself, we have to live off of our checking account. We can't have any in savings. So I just have to deal with that. And I take my T3 twice a day, and it's fine. I've been doing it for decades. But people who can, if we can give you a little bit of a savings account, I like that. I want you to have that. So if you can tolerate a little bit of T4, that's a win. If you can't, then you can't. And we deal with it, and you're T3 only, and that's okay. But ultimately, if we can give you a little T4, that's cool. So we look at that data to be able to say, like, okay, maybe we reduce your T4 and we change up this T4 to T3 ratio, which, by the way, we can also do with natural desiccated thyroid. So just because you're on NDT, and we said it earlier, that is 80% T4 and 20% T3, we can add in T3 to your NDT and change the ratio. So now if you're taking, let's say, Armour thyroid and liothyronine, now you're not stuck at 80-20. With that added liothyronine, now we've shifted it to maybe 70-30, maybe 60-40, maybe 50-50. So we can really personalize the treatment, but that marker, that genetic marker is just a beautiful thing to know in people. It directs the treatment, and it allows us to get you to optimal faster.
Yeah, and I would be very interested to at some point have an offline conversation with you about other things that are in people's genetic reports that might interface with suboptimal DIO2 that make it so that they are more the person who needs to take more T3 because isn't there doesn't inflammation sort of suppress this conversion also? So if someone had more markers for higher inflammation, maybe that would be something that would correlate to it. And so I just wonder how many different things that we could look at to sort of inform what the mechanisms are that make people who have seemingly the same gene in this one aspect, the other genes are informing it. And that's one of the reasons that we do polygenetic testing is because it's never just one gene. But it doesn't mean that other genes can't help you to understand your body and to understand what to bring to your provider in terms of saying, I think this is going on in my body and I have these predispositions. This is how I'm feeling. And so anyway, I just wanted to throw it out there that I'd love to
No.
have another conversation with you.
Oh, no, we definitely will. Because I would love for you to look at my DNA report from y'all and maybe teach me like what other markers could be tying together with that D101, D102 SNP. So that'd be interesting. I want to learn.
I wanted to go in a little bit and just touch on UCP1 also, because that's going to kind of swing us in the direction of T2, because I definitely want to get to that conversation before the top of the hour when we start our Q&A.
Mhm.
So do you want to talk about UCP1 or do you want me to talk about UCP1 and then in the context perhaps of T2?
However, I'll let you lead, and I'll chime in with my
Okay.
knowledge on it, and we'll blend it all together.
Sounds great. So all of you can look on your gene reports for UCP1, which is something that affects how you produce heat in as part of your mitochondria making energy. And so when people are more able to make brown fat and release heat as part of their energy making process, then their metabolism it tends to register as being higher, right? So it's they're burning calories at a different rate. So all of you can look and see in your reports whether you're optimal or suboptimal for this. And the thyroid can affect thermogenesis. And the expression of UCP1. And so we have thought about it specifically in the context of T3, but now we're starting to think about it also in the context of T2. So that's my little preamble, and now you can take it away.
I love it. I love it. Well, the first time I heard about UCP was back in my bodybuilding days. Bodybuilders were the OGs of biohacking. They really were. And that whole world was trying peptides and basically experimenting on themselves long before Brian Johnson decided to become the world's best biohacker. So where I heard it in the context of where bodybuilders were actually taking a pesticide, I think it was called DNP, that increased UCP. Basically, they wanted to burn as much body fat as possible. So when you increase that thermogenesis, when you increase the heat, when you can brown white adipose tissue and increase UCP, you are burning stored body fat. Your metabolism increases. Now, as Dr. Steady said, we are looking at this in the context of thyroid, because thyroid is the master regulator of your metabolism, specifically T3. T3 is a fat burner. I mean, it does produce that UCP, that thermogenesis, that fat burning. However, and I'll go back to the bodybuilding world. Years ago, I saw, when I was studying T2, and I've been studying it for about 15, 20 years now. It has over 30 years of research. But I saw this interview by a trainer to the top of the top athletes in the bodybuilding, fitness, and figure world. And he said, I only use T2 with my athletes. It's like, I don't use T3. I don't let them use these crazy fat burners. Because what we know is that even T3, when used and abused, when taken outside of the realm of thyroid treatment to just burn stored body fat, we know that it's going to shut down your thyroid and it's going to burn fat and muscle at the same time. With T2, it leaves muscle alone. It only burns stored body fat, increases your resting metabolic rate, produces more fat burning, more thermogenesis, browns white adipose tissue, reduces inflammation, reduces oxidative stress, and does not have a negative feedback loop on the thyroid to where your thyroid labs are going to change. Or in the case of people taking T3 or abusing T3, I saw a competitor come out the other side of a show with a thyroid problem. So you would see these women on stage and they're just most perfect, lean, muscular form. And literally 2 weeks later, I'd see them at the gym 20 pounds heavier. Yes, they're rebounding from the diet they were on, but you don't just rebound. That's a thyroid problem right there. They shut down their own thyroid production and caused themselves, basically brought on hypothyroidism because they used T3 when they shouldn't have. If they use T2, we don't have that problem because there's no negative feedback loop. So yes, T2 is fascinating. Like I said, it has over 30 years of research. The problem is that it only has a few, I think 2 human studies connected to it. And my theory is that there isn't a pharmaceutical. So T2 is available in supplement form. Thank God. Thank God it's available in supplement form so that we can all have access to it and we don't have to beg our doctors for it like we do with T3. But the other issue with it being in supplemental form is there's no pharmaceutical incentive to do a human trial. So anecdotally, I've been using it in my practice for years. And way back in the day, before I built the team that I have right now where we can prescribe to all 50 states, I was working with patients where they might be stuck on T4 only. And we already talked about elevated reverse T3, low free T3, people who don't convert well, they stay in this hypothyroid state, they can't lose weight, they don't feel better. So back then I was giving my patients this supplement bottle. It was from the bro science world. It was an angry supplement with a gorilla on it. And I said, trust me. And they did. And they lost weight. So I saw it actually overcome T4 only. That was the only thing that I could see push past that T4 only hurdle and actually improve quality of life and decrease symptoms. So just last year, we did a trial We started with 14 women. I think we ended up with 12 of them. Two of them dropped out for whatever reason, but it was kind of like our own clinical trial. And we did not treat any of these women. I looked at their thyroid labs, I looked at their hormone labs, I saw what they were taking, but they were not a patient. They were only a participant. So the only thing we could do, and believe me, I looked at some of them and I was like, oh man, there is no way we're going to overcome this. This is bad. This is really bad, but we're going to try it anyways. And we used 300 micrograms of T2 because I have it in my supplement line. It's in Thyroid Fixer and Metabolism Fixer. We gave them 300 micrograms of T2. That's what was used in the human studies. And in 16 weeks, they all lost weight. I'm talking about a woman that was on prednisone and T4 only. She lost 35 pounds post cancer treatment. I mean, we saw weight loss anywhere between 6 and like 40 pounds. All of them. Not one of them didn't lose weight. And some of them were very, very hypothyroid. So I want to reference one study that it was done on rats, but I do find it fascinating. And when I'm presenting on T2, I always pull this one up. It says, T2 3,5-diethylthyronine browns white adipose tissue in hypothyroid rats. Well, they didn't optimize the rat's thyroid and then give them T2. They left them in that hypothyroid state to see if T2 could overcome a low functioning thyroid, and it still did. So it still browned the white adipose tissue even in that hypothyroid state. And that's exactly what I saw with that group of women that we did the trial run on. So I find T2 incredibly fascinating and incredibly powerful, especially in this obesity crisis that we're in right now.
Absolutely. And so just so that all of you know, there is a link in the chat right now where I believe you can get 25% off of I think it's a 3-month supply of some of Dr. Amy's supplements. So feel free to take advantage of that.
Yep, that'll be Thyroid Fixer. And yes, you can get 25% on Thyroid Fixer, and that has T2 in it. So that was like the flagship product. I knew that's what I wanted to bring to market because I knew it worked. And so
Right.
it has T2 and it also has L-tyrosine, which is an important amino acid for thyroid production.
I know that we're going to get this question. I think they've probably shut down the Q&A at this point because we have so many questions in there. But is that okay to take if you're on thyroid medication?
Absolutely. Yes, absolutely. And I would say you need to take it if you're on T4 only. We know that. Or if you're on a higher dose of NDT, absolutely add that in for sure.
So we only have a few minutes to get into gluten and gut and autoimmunity. So we may have to try and have a part 2 of this to
We can do
really
that.
dive deeply in it. But I want to
Yeah.
just at least like skirt the surface because there are genes that are going to affect this that we could get into. But I just want to hear your stance on gluten and thyroid autoimmunity. And then I just think we're just gonna have to have this delightful guest back on to really dive into the gut stuff. Talk to us about the molecular mimicry concept and why you believe even small amounts of gluten can be harmful for people with thyroid issues.
Yes, absolutely. So I always say gluten-free is not just a fad. I know that we've been hearing more and more about it, especially over the last, what, decade, really. And, you hear so much about it that people start to roll their eyes like, oh yeah, gluten-free. But there's something to it, especially in the world of hypothyroidism slash Hashimoto's. If you have Hashimoto's, or really for that matter, any autoimmune condition, but we're really going to focus on Hashimoto's, you need to avoid gluten because the protein molecule in gluten is called gliadin. Gliadin, under a microscope, looks very similar to the thyroid gland. We call it molecular mimicry. And so what that means is, we talked earlier about those antibodies being soldiers. So when you have any autoimmune condition, you have those soldiers that are confused and they think that whatever is a bad guy. Hashimoto's, thyroid's a bad guy. Rheumatoid arthritis, your joints are a bad guy. Celiac, the villi in your small intestine are bad guys. And they like going out and attacking the bad guys. So when we eat gluten, those soldiers, they're always on surveillance. They go, hey, there's something coming in the system that looks like the bad guy. It looks like the thyroid gland. That's what we like to go out and attack. So I'm saying we launch an attack because this looks like an invader right here. So essentially, every time you eat gluten, you're spurring on that autoimmune attack. You're actually creating an attack on your own thyroid. And what we know is that those autoantibodies can increase as well. So oftentimes when we're looking at, let's say, a patient's numbers coming back, and I always tell people, like, don't hang your hat on your antibody numbers. Don't freak out if they go up by like 10 or 50 or whatever. Maybe you got glutened at a restaurant, right? Maybe you just one slipped by. But that those gluten molecules, those gliadin molecules specifically, can induce an autoimmune attack and grow your army. So you really want to be 100% gluten free. If you know that you have an autoimmune condition, if you know you have hypothyroidism, Hashimoto specifically, but I don't care, even if you know you have hypothyroidism, and you haven't officially been diagnosed with Hashimoto's, go gluten free anyways, because there's a 95% chance that your hypothyroidism is Hashimoto's. So why don't you just do it? It's so easy these days. There's no excuse not to.
Awesome. And you ended at exactly 7. I mean, that was amazing. Okay.
So,
Perfect. So we will have Dr. Horniman back, and we'll dive into some of the genetic tie-ins to all of that information. But she brilliantly was able to really summarize that very nicely in a very brief period of time. So let's get into our Q&A. So our first question is what do you see as the connection, if any, between TSH and osteoporosis? So she's saying suppressed TSH, but like what's up with the thyroid and osteoporosis? Let's kind of make it a bigger question.
okay. So the thyroid will control bone turnover. So just like it has an effect on our skin cell turnover, bone growth, bone turnover, it has an effect on that. Now you're going to double up on that on your osteoporosis chance if your progesterone and estrogen are low as well. So if you have low thyroid, low estrogen, and low progesterone, that's a beautiful trifecta for osteoporosis right there. Add on top of that, if you're low in mag, vitamin D, K, and you don't exercise, just you're pretty much guaranteed. However, a low TSH does not cause osteoporosis. That is a fallacy. It's a myth. It's false. Get it out of your head. I know doctors still hang on this. I don't know where they learned it, when they learned it, how long ago that was circulating around, but they need to update. They need to update their information. Now, again, if you have a 75-year-old that has a TSH of a 0.007 and she's not eating hardly anything and she's not taking nutrients and she's not doing weight bearing exercises and she's not on hormones, and you continue to suppress her TSH, yeah, that whole mix can cause osteoporosis, but it's not one thing. And it's not just low TSH. So if we really step back and even look at what is TSH? TSH is thyroid stimulating hormone. So it's from your pituitary telling the thyroid, it's released from the pituitary to tell the thyroid, hey, thyroid gland, you're not making enough thyroid hormone. You need to wake up and do your job. That's why when TSH goes up, it's screaming, yelling louder at your thyroid. It's not a thyroid hormone, it's a brain hormone. So whenever, let's say we actually put you on the right thyroid hormone replacement, which includes T3, and I'm not talking like a little baby dose of here's 5 micrograms, yay, go on your way. I'm talking about actually optimizing you to the T3 level that you need, whatever that is. Mine, I used to take a total of 150. Now I'm down to 100 micrograms a day. I have another patient on 100 twice a day. She's on 200 micrograms of T3. I have other patients that are on 25 micrograms twice a day. I have patients that are on 10 micrograms twice a day. Wherever your optimal is your optimal. So there is no average, but any amount of T3 is going to suppress your TSH because of that feedback system. Think of your brain as like, it's almost like a sensor, right? It's got feelers out. It's going, is there enough thyroid hormone here? Is there enough? Is there enough? Is there enough? Naturally, if there's active thyroid hormone, if you're taking T3, your brain goes, hell yeah, there's enough. We are so happy. And TSH goes down because it says, listen, we don't have to yell at the thyroid anymore. It's doing its job. Well, at least it thinks it's doing its job, but it's just sensing there's enough thyroid hormone in the body. So TSH goes down. TSH will go down even if you're on T4 only. Even when T4 only isn't working, TSH will go down. And I'm going to give you one more argument to this too. Why is it that we suppress the TSH of post-thyroidectomy cancer survivors, but then we all of a sudden freak out if the TSH drops in a non-thyroidectomy, just hypothyroid patient? That doesn't make sense. We actually suppress the TSH on purpose to reduce the chance of tissue regrowth, i.e. cancer regrowth. Why is it okay in that population but not in this population? It doesn't make sense. Bottom line is you don't have to worry about TSH being suppressed.
Awesome.
I know that was a long answer to a short question, but it's
No, but it
important.
it gave a lot of information about a lot of different things, so I think it was perfect. Um, we have someone asking if a new acute illness that lasts 6 weeks or chronic illness, can that cause thyroid function to change?
Yes, it can. It can just be like a thyroiditis or a thyroid inflammation situation. You want to keep an eye on it. And after you get past that illness, then you know, definitely retest, pay attention to your body and your symptoms. If the symptoms don't alleviate themselves, retest, look at your thyroid through an optimal lens because it could have taken a hit and it might stay that way, or it just might be a temporary inflammatory state.
Next, we have a question. If one is detoxing from high levels of mercury, lead, and mold, is it better to wait until those levels decrease before testing the thyroid levels, or the thyroid levels not really impacted by those toxins? And I guess what I would like to add to this is if your thyroid isn't functioning well, does that impair your ability to recover from those things? So sometimes I add in my own little little
Well, I'm
twists.
glad you did because that was on my mind. If here's the thing, people, detoxes are so popular these days. Everyone wants to, hey, I have this heavy metal detox and I have this detox and that, and the Beyonce cayenne pepper detox. There is no detox that is truly going to work without your thyroid functioning properly. That is your detox pathway. Like, if your thyroid is not functioning, your liver is not functioning properly, your circulation isn't, your digestion, your elimination, everything is slowed down. How are you even going to detox with whatever protocol you're using from those heavy metals? I mean, that's pretty heavy. Mercury, lead, and mold. Like that's a heavy detox right there. Your body's not going to be able to do that if your thyroid's in the toilet. So actually, I would rearrange the question or rearrange my answer to say thyroid first. Put the detox on the back burner. You check your thyroid first. You optimize that first. Then you can add in your detox protocol because your thyroid's working optimally. Now the detox protocol will work. Now, yes, if you retest during a detox, your thyroid numbers can look wonky, but that's okay because you already tested before you did the detox in the first place and you got optimized first. So you know that that's okay. So that when you test and you see some wonky numbers, you go, okay, that's all right. I'm going to retest after the detox is over and then adjust accordingly.
So I have someone asking if the 360 report includes the DIO2 gene, and it does. Um, I'm going to say, please join the Facebook group because I'll tell you, it might be, I used to know, I want to say it's in diet and nutrition, but I want to check both the older report, the original report, and the new one, just to make sure that I'm correct about where it is. So please check in the Facebook group and I will answer this question in there. For those of you who haven't joined the Facebook group yet, let's put the link in the chat for the Facebook group, which is where I can interface with people after the webinar's over. Okay, now we have someone asking, please explain what levothyroxine medication helps with. I have low thyroid and take 137, my glasses. Uh,
Micrograms.
yeah, thank you. Of
Yep.
above medicine. There we go. Wonder it's the trifocals.
Uh-huh.
Wonder if I should go ask to go on Armour thyroid medication might help me more.
Okay. So first of all, get the book because that's going to guide you. Second of all, so Levo is what we were talking about. That's T4. So that's what we've been saying. T4 only doesn't work. T4 only doesn't work. More T4 will drive up your reverse T3. So I would say if you're on T4 only and you have symptoms still, any of the symptoms, then you're not quite optimal because those symptoms are just it's data, it's gifts given to you by your body to say, hey, look a little bit deeper. Something's off, something's not right. I would say definitely 1,000,000% you want to test your free T3 and your reverse T3. That reverse T3, if it's above a 12, is going to tell you you are on way too much T4. And just like we already talked about, it's also going to give you it's going to give you direction to look deeper. Look at your insulin, estrogen dominance, nutrient deficiencies, stress, inflammation. Like look at all those markers to see if that's driving your reverse T3. But 137 micrograms is a lot of T4. It's a lot. So the answer, should I switch to Armor? Maybe. Don't know. We need to know what your reverse T3 is. And it's not necessarily that Levo to Armor is the best switch. It sometimes is for some people, or sometimes we just keep the Levo, drop the dose, add in T3. So that way you're not changing over to an entirely different medication, different dose. Now we have to see how your body tolerates it. Does it have an autoimmune reaction? Because some people can to natural desiccated thyroid. So for you, I would say let's check reverse T3. Let's look at free T3, and then let's adjust that medication, maybe bringing T4 down and adding in the T3.
Excellent. Thank you. Now someone is asking, what is the optimal range for free T3?
Upper quadrant of the range. So just take that, whatever lab you've gone to, take that standard lab value range and cut it in the 4. So you want to be in the upper fourth, the upper quadrant of the range, or you just a little bit over is fine too.
Perfect. Someone is saying that they saw something recently about selenium toxicity, and it mentioned 200 micrograms being too high a dose, but they thought that that was recommended to help the thyroid convert T4 to T3. Do you have any comments on that?
I like 100 micrograms of selenomethionine specifically, that form of selenium. You're right. I mean, some people can't handle 200, but what I see, and thyroid patients are notorious for this, they will read a blog, they will see an Instagram post that selenium, the thyroid needs selenium. Selenium is fantastic. You need selenium, you need selenium, and they will go out and they will buy 200, 300, 400. More is better. More is better. I'll take a selenium pill and I'll do Brazil nuts all on the same day. And yes, you can push your selenium too high, which also can push up your reverse T3. So selenium is very, very Goldilocks. It's like you just need to find that just right level. And I prefer 100 micrograms. So that's what I put. We have a product called T3 Conversion Fixer, which actually helps convert T4 to T3. It's all the nutrients that you need. Outside of iodine, we have iodine separate because I like dosing iodine separate. I like it in a liquid form. So we did not put it in a capsule form into T3 Conversion Fixer, but it does have selenomethionine in it.
Excellent. Someone is asking, can low libido be connected to only thyroid, or is it always connected to multiple things?
Multiple. Now, I mean, okay, could we find one person who has a low libido, we fix their thyroid and it comes back? Sure. But it's usually other factors as well. It's so libido and hair are those two symptoms that have so many different factors. Like even fatigue, we can narrow it. Yes, there's a lot of factors factoring into fatigue. Absolutely. But wow, libido and hair. I mean, it's just there's so many different factors that play into it.
And now someone's asking, how are T3 values related to the free T measurement?
So
I,
you mean like
I
I
guess
think
I
she
guess they want you to compare and contrast T3 and free T3 is that's how I'm interpreting that question.
got it. Got it. Okay. So your total T3 is the amount of bound T3 in your body. Free is the unbound form. So it has to be in its free form to actually attach to your cell. So total T3 is one that we don't test all the, if it's thrown into a test, we'll look at it, but it honestly doesn't, it doesn't give us enough data without the free measurement. So you have to have the free T3 on your test, not just the total.
Someone is asking, where's a good place to learn more about different medications and that help with the different, with T4 and T3? I'm going to say your book, but that comes out in May, right?
Yes,
So, is there stuff on your website that they can look at in the meantime until they can have it all condensed in a beautiful book?
we
Um,
do. Yes, yes,
okay,
yeah, we do. So on the site, and I'll find it and I'll pop that in the chat, the link. But we have, if you go to dramie.com and then under resources, we have a ton of freebies there. So, of course, you'll find the podcast and whatnot. But under the freebies, we have the 12 critical tests your doctors refuse to run. And then we also have the ultimate lab guide. So, I'm going to grab this ultimate lab guide and pop this into the chat.
wonderful.
And
Thank
that
you.
will give you the labs and the optimal ranges for where you need to be. Now, that's the lab. You asked about medications. So let me go here. And we have a 7-day thyroid reset Kickstarter. So I'll put that in too, where I talk about the medications. But in a nutshell, I'll just give you the brief rundown right now. On the T4 category, you have levothyroxine, Synthroid, which is brand, and Tirosint Sol, which is brand. So Levo is the generic. Then we go one step higher, Synthroid. Then we go Tirosint and Tirosint Sol. Over on the T3 side, we only have two. It's liothyronine generic, Cytomel is brand. And then right in the middle, we have the NDT, natural desiccated thyroid, which we have Armor Thyroid, NP Thyroid, Ren Thyroid. Used to be Nature Thyroid, but that got taken off the market. I don't think WP is still around. And that's your porcine derived 80% T4, 20% T3 medication.
Excellent. I'm just asking them to put those in the chat for everyone because I think
Oh, I see. I think I
you
didn't
and I
host
are,
the panelists. Yeah.
it's okay that Vanny and Maya will take care of us. So, okay. So someone's asking if they don't have a thyroid because of a history of thyroid cancer, it was removed. Do they still
Mhm.
need to take iodine?
Oh, yes. Okay. So iodine is vital for every single cell in your body. It is antiviral to the max. I haven't gotten sick in 2 years because I take my iodine every single day and I double up if I have to get on a plane. And I even put it in a little nose spray bottle with some saline, squirt that in my nose when I'm on the plane. So if we look at the science of iodine, we look at the periodic table, if iodine falls into the halides or halogens, we are all exposed to fluoride, chlorine, and bromide every day. Even if you don't use fluoride free, if you do use fluoride free toothpaste, you use fluoride toothpaste at some point, and you probably had those little pink pills that your dentist gave you, like the fluoride treatment, right? And it's in our water system. So unless you have a whole house reverse osmosis water filtration system, and unless you never, ever drink water when you're outside of your house, you're going to be exposed to fluoride and chlorine. Bromide, clothing, baked goods, carpets, floors, furniture, grass. It's everywhere. It's everywhere. So those toxic halides that are toxic to your thyroid, but really toxic to your whole body, will compete at the receptor site on your cell for iodine. If you do not have enough iodine, those toxic halides will attach to the receptor site on your cell and take over. And then you are looking at an increased risk of thyroid cancer, thyroid issues, the whole gamut, because you have toxins in your body, as opposed to beautiful iodine that is antiviral, antifungal, antibacterial, needed by your thyroid to produce T4 and T3, needed by your thyroid to convert T4 to T3. Yes, we all need it, even without a thyroid.
And this is also where knowing your detox pathways that may help or not help you as much to detoxify these substances
Mm-hmm.
could be really beneficial, and where looking at your gene report is helpful. We had a quick question, which was, what, I don't know if you feel comfortable answering this. Maybe it's already in your book, and so it's fine. What's the dosage that you recommend? Does that vary depending on the person, or is there a standard dose that you think is safe for the entire population to take?
For iodine. So I really prefer liquid iodine because you can titrate up very slowly. Where your dose is going to be very unique to you. It's just like T3. It can be anywhere. So I'm a high tolerance person. I take large amounts of T3. I take large amounts of estradiol, like I shared. I can take large amounts of iodine and not be affected. Whereas Susie Q over here might take 6 milligrams of iodine, where I'm taking 50. And at 6 milligrams of iodine, she's like, woo, okay, the lights have turned on and I feel good, but I'm just maybe a little bit jittery, just a little bit. Or she might have like a little bit of a detox reaction where she's like, ugh, I feel kind of sick and icky for a while. And that's her body detoxifying. So when you start iodine, I always say start with 1 drop in a shot glass of water, go up by 1 drop daily. Pay attention to your body. If you start to feel like, wait, all of a sudden, did I drink 6 Red Bulls today? Did I have 1 too many cups of coffee? Then you know that you went a little bit too far because you'll feel a little bit hyper. And that's when you back down. You go back to the last dose that you were at yesterday or the day before. You add in some salt, you take vitamin C, that will balance your system out. Salt helps your body utilize the iodine, and then you just drop your dose. Now, maybe down the road, a month from now, you'll be able to increase again, but you increase your iodine very, very slowly while paying attention to your body signs and symptoms. I like to try to get people anywhere between 6 milligrams and 50 milligrams. Where you fall is unique to you.
Thank you. Our next question is, what can you do to get your TPO antibodies down to 0? This person has had them in the 300s for years and is just really struggling and would like to have that be different.
Oh yeah, we can totally, at 300, we can push that to 0. So we have seen multiple people go into remission using black cumin seed oil. Now, here's the key. So we do have this, it's a shameless plug for my supplement, absolutely, Hashimoto's Fixer, but I'm proud of it because it contains 3% thymoquinone. That is the key. There's a ton of black cumin seed oil out there. Most of them are not 3% is the highest you can go. So as somebody in my Facebook group, they posted a picture. They're like, well, this is 50% thymoquinone. I'm like, then it's fake because it actually can't get that high. 3% thymoquinone, the active ingredient in black cumin seed oil is the highest you can go. But you want that 3%. And yet we have had many, many customers, not even patients, just customers using it, writing in saying, it pushed my antibodies to 0, or it dropped my antibodies by 200, 300 points. So you have to do that. Go gluten-free, obviously, control your stress. And sometimes if we have a patient where their antibodies are in the thousands, we'll stack black cumin seed with low-dose naltrexone. But with antibodies at 300, I think you do really well with just black cumin seed.
Thank you. We have someone asking how does BHRT affect the thyroid? Since starting with some pellets last year, TSH has increased, free T3 has gone down slightly, and free T4 has maintained. Reverse T3 was only tested before and was at 16. The endocrinologist is thinking about Armour, but she thinks that there is something else impacting it, and is curious if she started at a low dose of Armour, can you come off of that, or does it impact the natural process of creating thyroid hormones?
Okay. So let's see. First of all, thyroid and sex hormones play together. So that's why I always look at both. We don't just do one and not the other. But like we said earlier, higher doses of estrogen, estradiol, can impact the thyroid. So with a pellet, I've seen good and bad. I've seen some pellets really push a woman into estrogen dominance. I've seen testosterone levels go to a 900 in a female. I've just seen some wild things with pellets. So, and then I've seen pellets that are done the right way. So it's hard to say. We don't know what's happening with your pellet and with your hormones and how much that estradiol in the pellet is going, how much of it is it spiking? Are you going into estrogen dominance? Is it increasing your TBG? Is it affecting your thyroid hormones? We don't know. That TSH going up, okay, it's indicative of like, yeah, there could be a thyroid problem there. It could be totally independent of your bioidentical hormone replacement. It could just be that you are in thyropause, or that the Hashimoto switch turned on, or you're developing a thyroid problem for other reasons independent of the hormone replacement therapy. Now, you said your endo wants you to start on Armour. So what we have already said is that Armour is 80% T4 and you have a reverse T3 of a 16, or at least you had. I would recommend getting a full thyroid panel before you start on any thyroid hormone replacement. Now, if you start on thyroid hormone replacement, I want you to think of it differently. I want you to put thyroid hormone replacement in the same category as bioidentical hormone replacement. So you're a woman, you're in menopause, you start on BHRT, you feel amazing. We add in estrogen, we add in progesterone, we add in testosterone, and you're living your best life. Would you then go off of those hormones? Are you all of a sudden going to age in reverse like Benjamin Button and produce more hormones like you were in your 30s without actually replacing the hormones? No. So the same thing goes for thyroid. If you truly have hypothyroidism, if your thyroid is not producing T4 and T3 in proper amounts anymore, if you've had Hashimoto's for years and nobody diagnosed you, and your thyroid gland is so beaten up that it's itty bitty and there's no possible way that it's going to produce T4 and T3 in adequate amounts, then we want to replace those hormones. There's nothing wrong with that. It's thyroid hormone replacement, just like it's sex hormone replacement. Yes, you're going to have to be on that the rest of your life, but who cares if it gives you quality of life? You're going to have to pry my thyroid hormone out of my dead, cold hands before I ever go off of it, including my sex hormones. Like I will be in the grave, and that will be the only time that I won't be taking hormones anymore. So once you're feeling good, you won't even have that thought. You won't even have that thought of, well, if I start it, can I go off of it? You're going to be like, I started this and I feel amazing, and you're not taking it away from me. So that's what I would say. There's a lot of factors in that question that we just don't know.
We have a quick question. How long should you wait to get your blood drawn after taking thyroid medication? So is there a, if you take it, most people take it in the morning because that's what's recommended. Is it like, would you get your blood drawn before you take it in the morning, or would you do it? When's a good time?
Love this question. I love this question. Okay. This is the rule. I don't care what you see on Instagram. I don't care where you've heard this anywhere. I want you to follow this rule. Promise me. When you test your thyroid, if you are taking anything with T3 in it, that's liothyronine, cytomel, natural desiccated thyroid, or even a thyroid glandular supplement, you have to test 18 to 24 hours after your last dose. So let's just say you're taking T3 and we have you split dosing it, because I really prefer split dosing T3. Take one dose in the morning, the other dose you put in the afternoon, because T3 has a very fast action on the body, a quick half-life. So we split dose it. So you take that second dose of T3, let's say at 2 p.m. in the afternoon, and then you have your lab scheduled for the next morning. You would normally wake up and take your thyroid medication, but on this morning, you're not going to. You're going to go to the lab at, let's say, 8, 9 a.m., and that will be roughly 16, 17 hours post your last dose. That's perfect. Well, no, wait, that'll be 18. I'm doing math wrong. 18 and 19 hours. That's perfect. You don't want to go less than 18, and you don't want to go more than 24, because here's what happens. So when you take that T3 thyroid medication, and T4 is not the same. T4 is very, very slow acting. So, I mean, I tell people just hold it anyways. But if you slip up and you take just Synthroid and you go to the lab, I'm not going to make you redo your lab. But if you slip up and you take your Armour, you take your liothyronine in the morning, you're making another lab appointment. You're going to go back because we're going to get a false reading. So what happens is you take that medication, now it's in your bloodstream. Now, like I said earlier, everyone is on a different dose. Everyone has a different optimal of their T3. Susie Q might be at 10 micrograms twice a day. I'm at 50 micrograms twice a day, and my other patient's at 100 twice a day. We're all going to get different free T3 levels if we take our medication and then test our blood, because we have now different microgram amounts coming in our bloodstream. That test, if you take your med and go to the lab, you are basically pulling the medication into the lab result. I've seen free T3s of 6, I've seen 12, I've seen 16, I've seen 20. Who's right? Where is there ever a written down optimal free T3 value while testing at the peak? There isn't one. There isn't one. The Institute for Functional Medicine and Functional Medicine University and every functional medicine training course out there does not have an optimal free T3 level for testing at the peak. You have to test 18 to 24 hours after your last dose of thyroid medication to get an accurate result. And that's that window where we can say we want you in the upper quadrant of the range. But if you test earlier than that, you're going to get a false high. If you test longer than 24 hours, now you're getting a false low. Now your VT3 might be rolling in at like a 2, but it's not really because you just went 36 hours. So you want to test 18 to 24.
Perfect. We are at time. So we have some unanswered questions, and I'm just going to tuck them away for when we do our part 2.
Okay.
Um, and we will get to them. Do you have any parting words for our audience? This has just been so wonderful. You are delightful and have so much wonderful information to share. Do you have any final words for our audience this evening?
So I always like leaving people with this. If you have symptoms, those, like I said earlier, are gifts given to you, GIFTS, gifts given to you by your body to say, hey, there's something more here. There's something deeper going on, and we want you to pay attention. Now, we all know that when our body whispers, if we don't listen, it's going to scream. So definitely, please listen to the whispers. Pay attention to the gifts your body's giving you and get thoroughly tested. I mean, we test all thyroid, all hormones. We look at the whole thing, right? And now you have the beautiful DNA to overlay. You can get such an amazing picture as to what is going on inside your body and why you have those symptoms. And then you can get direction as to what to do about it so you can regain quality of your life. And that's what it's all about. And the last thing I'll leave you with is hope, because you have to keep going. I mean, I often think, what if I would have stopped at doctor number 5, doctor number 6? That is 6 medically trained professionals who all told me I was normal, I was fine, everything was fine. You have to hold on to hope that things are going to get better, because you know your body better than anyone, better than I do, better than any doctor, better than any expert. You know your body. So if something's not right, you hold on to that hope and you keep going. And I don't care if you see 7 doctors, if you see 10 doctors, if you see 15 doctors, someone will have the answer. Now, of course, we're here for you if you need, but you keep going. You do not stop until someone treats you properly and asks you, how do you feel? Because remember, that's rule number 1, 4 most important words.
Awesome. Well, thank you so much. Everyone, pre-order the book. Get that 25% off discount. All of those things are in the chat. Thank you so much, Dr. Horniman, and I'm already looking forward to next time.
We definitely will. Absolutely.
Thank you, audience. Have a wonderful evening.